Now starting with glomerulonephritis, I'm reading it from edition 6 of Marrow. So the hallmark of glomerulonephritis is hematuria. Gross, we can see the cola colored urine, and in microscopy we will find more than 5 RBC per high power field in uncentrifuged sample and more than 10 RBC per high power field in centrifuge sample. So the main thing that we will see in glomerulonephritis is hematuria. Now the additional findings that can be seen are, we can find the RBC cast, okay, and dysmorphic RBC is more than dysmorphic RBC is more than 20%. So diagnostic for hematuria associated with glomerulonephritis, dysmorphic RBCs, right? The shape of the RBCs will be distorted in almost more than 20% of the RBCs. There will be mild proteinuria. Proteinuria is mainly a feature of nephrotic syndrome, right? That is massive proteinuria. Mild proteinuria may be found in glomerulonephritis. Massive proteinuria is seen in nephrotic syndrome. Edema may be present, pedal or periorbital. Presence of hypertension is an important feature here, right? Child would be admitted for BP monitoring and antihypertensive administration. There will be oligouria, and overall most common condition associated with glomerulonephritis is post-streptococcal glomerulonephritis. Organism which is associated is the group A beta hemolytic streptococcus. Group A beta hemolytic streptococcus, right? Now coming to the infection, there is pharyngitis. Skin infection is pyoderma and impetigo. Post infection is lag period, then glomerulonephritis. In the lag period, few weeks post infection disease develops. Okay, so what we read here is findings of the glomerulonephritis. Main were hematuria with dysmorphic RBCs, mild proteinuria, hypertension, and most common condition is post-streptococcal glomerulonephritis. An organism is group A beta hemolytic streptococci. Infection can be pharyngitis, skin infection also, right? Now starting with the pathophysiology. At the lag period, streptococcal antigen and anti-streptococcal antibodies combine, forming the immune complex and deposit in the kidney. Okay. So there will be immune complex deposition in the kidney. An immune complex will be formed by the streptococcal antigen and the streptococcal antibodies. So the type of infection, let's look at that. In respiratory infection can also lead to this glomerulonephritis, and skin infection also. Respiratory infection are more common during winter and skin during summer. The strain which causes this glomerulonephritis in respiratory are M4, M12 commonly, and M1 and M24 also. And there is a lag period, that means after the respiratory infection it will take around 1 to 2 weeks for patient to present with glomerulonephritis, and with skin infection the lag period is more, that is 3 to 6 weeks. Features, age group is school going children. It will affect 5 to 8 years. Investigations, there we can do the antibody titer, we can in which the ASO titer is increased. Okay, in glomerulonephritis the ASO titer will be increased. ASO is anti-streptolysin O. If ASO is normal, then anti-DNase B will be increased. Okay, so what we saw was there will be antibody titer increase, ASO and or anti-DNase B increase. Now the serum C3 decreased as the complement used for the immune complex formation. So serum C3 will be decreased. If we do the renal biopsy, but it is not indicated, right? It is rarely indicated. Low C3 will be for more than 12 weeks and impaired renal function for more than 7 to 10 days. Findings seen are, these are the conditions when renal biopsy is indicated, like if C3 is low for more than 12 weeks and impaired renal function. And findings seen on the renal biopsy is that on immunofluorescence microscopy there will be deposition of IgG and C3 in the capillary wall, seen as lumpy, bumpy and the starry sky appearance. Okay, and on electron microscopy subepithelial immune complex deposit called as the humps. Fine. So what we saw on immunofluorescence, lumpy, bumpy and starry sky appearance, and on electron microscopy we can see subepithelial immune complex deposition called as the humps. Fine. This was all the investigations which need to be done in the glomerulonephritis. Main was ASO titer increase, anti-DNAs B increase, serum C3 will be decreased, and renal biopsy if C3 is decreased for more than 12 weeks and impaired renal function for more than 7 to 10 days. And on findings seen on the renal biopsy on immunofluorescence microscopy will be lumpy bumpy appearance and starry sky appearance due to the deposition of what? IgG and C3 in the capillary walls, and on electron microscopy immune complex deposition subepithelial called as the humps. Fine, then how will we manage the case of glomerulonephritis? There is symptomatic treatment post-infectious, so will resolve by itself. Fine, we don't have to do much, but we have to give antihypertensive drugs like amlodipine and nifedipine. Okay, and natural disease course is resolution in few days to few weeks. But general guidelines, ASO titer and BP will be normal by 4 to 6 weeks and C3 will be normal by 8 to 12 weeks, right? And if it's not normal by 12 weeks, we will do renal biopsy. Microscopic hematuria can persist up to 1 to 2 years. Okay, so these are the things that we should remember. ASO titer and BP will be normal by 4 to 6 weeks. It will take around 1 month. For it to be normal, and C3 it will take around 3 months. And for microscopic hematuria, around 1 to 2 years also can also be required. Post streptococcal condition, rheumatic fever and PSGN. These are also post-streptococcal condition other than glomerulonephritis. Antibiotic administration can prevent the rheumatic fever but not PSGN. Okay. So if in streptococcal sore throat, if it's happening and we give antibiotic, it will prevent against rheumatic fever but not against PSGN. Fine. Let's move ahead to IgA nephropathy. Primarily because of IgA deposition in the kidney. Okay, IgA deposition is there, also known as the Berger's disease. Most common cause of the chronic and recurrent nephritis. Recurrent episodes follow any respiratory infection. If there is any respiratory infection, then the patient will have these episodes and lag period of only 1 to 2 days. Investigation that we do are C3 and ASO titer are normal. Renal biopsy is diagnostic. There will be mesangial proliferation with IgA depositions, right? Mesangial proliferation, and in that which depositions were seen? IgG and C3, right? And here IgA depositions will be seen. In 10 to 20% of the children with the IgA nephropathy can develop chronic kidney disease in the adulthood. Okay, 10 to 20% of the children can develop chronic kidney disease in adulthood with IgA nephropathy in the childhood. Okay, and management is by ACE inhibitors or ARBs. This delays the progression of kidney disease, hence decreasing the occurrence of the CKD, right? And fish oils can also be used because they are rich in PUFA and omega-3. They will decrease the entry of macrophages into the glomerular mesangium. Decrease what? The entry of macrophages into the glomerular mesangium, which is initiating factor for the IgA deposition. Okay, let's move ahead to hereditary nephritis. Hereditary nephritis is also known as the Alport syndrome. Most common mode of inheritance of Alport syndrome is X-linked dominant. Also have X-linked recessive and X-linked autosomal inheritance also, but most common is X-linked dominant. Defective gene is codes for type 4 collagen. So there will be defect in the type 4 collagen. There is a triad of hematuria, ear manifestation and ocular manifestation. Fine, he can't even see, he can't even hear, and he can't even pee. So in ear manifestation there will be high tone, high frequency sensory neural hearing loss. And on ocular manifestation, on slit lamp examination, anterior lenticonus is seen, and others are corneal erosion and macular flex. Now this is the anterior lenticonus that will be seen in Alport syndrome. And investigation, we do the biopsy, shows irregular thickening and thinning of the basement membrane plus lamellations are present. This is known as the basket weave appearance. Okay, there is irregular thickening and thinning of the basement membrane with lamellations are present. So this is known as the basket weave appearance. And genetic testing for the COLA gene defect can be done. Treatment. Supportive treatment with the ACE inhibitors can modify the progression or decrease the incidence of the CKD in children. So ACE is given in almost all the kidney diseases that we have read so far. Okay. Most children develop end-stage renal disease by second or third decade itself. Okay. And renal transplantation is done for prolonging the survival. So this was all about that we read in glomerulonephritis. Let's revise quickly. Glomerulonephritis main feature is hematuria, dysmorphic RBCs more than 20%. There might be mild proteinuria, but there is hypertension, and most commonly it occurs after a streptococcal infection, and the most common condition is post-streptococcal glomerulonephritis caused by group A beta hemolytic streptococcus. It can be either after a skin infection or pharyngitis, and there is a lag period. So in respiratory infection the lag period is only 1 to 2 weeks, and in skin infection lag period is 3 to 6 weeks. Its features are it affects the school going children between 5 to 8 years. On investigations we do the ASO titer, which will be increased, and if ASO is normal we do the ntDNase B, which might be increased. Serum C3 is decreased, and renal biopsy is indicated only if serum C3 is decreased for more than 12 weeks and there is renal function impairment of more than 7 to 10 days. And on renal biopsy we will see lumpy bumpy appearance on immunofluorescence due to IgG and C3 deposition, and on electron microscopy we will see humps due to immune complex deposition in the subepithelial area. Management is symptomatic, it's post-infectious, so it resolves by itself, but to manage the hypertension we will give amlodipine or nifedipine. And general guidelines include ASO titer and BP will be normal within 1 month, C3 will be normal within 3 months, and microscopic hematuria can persist up to 1 to 2 years. Antibiotic is given, but it will only prevent the rheumatic fever, not the post-streptococcal glomerulonephritis. In IgA nephropathy we saw IgA deposition, also known as the Berger's disease, most common cause of the chronic and recurrent nephritis, and recurrent episodes can occur after any respiratory infection. There is only 1 to 2 days of lag period. And on renal biopsy, which is diagnostic, we will see mesangial proliferation and IgA deposits, and in 10 to 20% of the children with the IgA nephropathy, chronic kidney disease will be seen in the adulthood. Management is by the ACE inhibitor or the ARB. It delays the progression and decreases the occurrence of CKD, and fish oil can be used, which decreases the entry of macrophages into the glomerular mesangium. Okay. Now the hereditary nephritis, also known as the Alport syndrome, most common inheritance is X-linked. It defective gene is COLA, which codes for type 4 collagen. There is a triad of hematuria, ear manifestation, which includes sensory neural hearing loss, and on ocular manifestation there will be anterior lenticonus. On investigation we will see basket weave appearance. It is due to irregular thickening and thinning of the basement membrane. And treatment we give the ACE inhibitors, and most children develop end-stage kidney disease by second to or third decade in Alport syndrome, and to prolong the survival we can do renal transplantation.